All right, this second lecture is going to be on the COVID-19 pandemic clinical pathophysiology. And again, I could spend 4 hours speaking just on this, and Al will kind of segue into this and talk about the treatment of COVID-19. My idea here is to just try to show you quickly the pathophysiology. So the learning objectives are going to be describe the clinical characteristics associated with COVID-19, review the pathophysiological responses to COVID-19, and describe the clinical symptoms of COVID-19 salient to organ systems. Because again, I'll argue COVID-19 is not just a respiratory disease or process. So when we look at the clinical presentation of COVID-19, there's fever and nausea, which is loss of taste or smell, dyspnea, dry spasmodic cough. Most of these patients don't have a lot of secretions, at least initially in the process. And secondary symptoms can be headache, diarrhea, bluish toes and fingers, which we call COVID toes and fingers. Confusion and stroke is quite common. When you look at the individuals that have symptoms, cough is by far the most predominant symptom. Headache, and then it kind of decays down to conjunctivitis at this point. But again, there's a whole plethora of symptomology. And again, the symptoms can appear in 2 to 14 days after exposure, things like that. One of the problems with COVID has been that, unlike most viruses, the transmission time is usually 1 to 4 days. COVID is 2 to 14 days. Oh, here we go. So what we look at is when you track COVID in humans, day 1 to 3 onset of symptoms, 80% of patients get just mild symptoms. 4 to 9, you can get lung involvement. 14% end up being infected with severe, all right, and you get severe inflammation, and 5% seems to be where you get septicemia and you get multi-system organ involvement, and then you get things like ARDS. And it's kind of interesting, by week 3, that's a crucial period, because if the patient still has COVID by day 21, they have a good chance of getting really, really sick. So for deaths, people studied generally died between day 15, 22 from the onset of symptoms, and people that were discharged was day 18 to 25. So week 3 is really, if you haven't got better by week 3, your chance of getting on this side is somewhat reduced. And really, when you look at from the alveolar level, you can look at the nice healthy alveolus here. You see gas can come in. There's no fluid meniscus. There's no cellular debris. There's no inflammation at the alveolar capillary membrane, and gas can go through the hemoglobin and get happily transferred to the cell. Now, when you start getting infection, you start getting the increase of spike protein. You start getting some inflammatory process, and you start developing moderate. You end up getting fluid. You got debris, but you still have some patency in your alveolus. So maybe oxygen will improve your gas exchange here. But as you progress to severe COVID-19, and we call it ARDS at this point, which we'll talk about in a second, that may not be accurate. The definition of may not be true ARDS. But my point being that, when you look at alveolus healthy and alveolus severe, you can see why gas exchange is tremendously impaired at the alveolar capillary level, because you can't even get air into the alveolus, and obviously you can't get it across the alveolar capillary membrane because you have a plethora of fluid, you have debris, and then you have a scarred, inflamed alveolar capillary membrane. So you do have this smell loss, and again, I'm not going to read all this stuff here because that's not that's not a presentation. I put this in here as a quick note thing for you guys, because these are on. You can access these presentations on the websites. But the bottom line is, you end up having your olfactory epithelium and respiratory epithelium. And when you get the COVID in here, your secretory cells and your basal cells, they end up becoming, infected and becoming paralyzed, which then prevents your cilia from moving adequately to kind of remove these viruses, effectively with sneezing or with, blowing your nose with mucous membranes, and that actually paralyzes cilia, and it also paralyzes your ability to smell also. So, as I said, when you compare the coronavirus to seasonal flu or common cold, you have the symptoms are a little bit different, okay? But this is what I really want to stress is the incubation. 1 to 14 days, as many as 24 days. So someone could be asymptomatic and transmitting disease up to 2 weeks, maybe even possibly 3 weeks, where usually seasonal flu, it's only a few days, and with a cold, a few days. You don't, transmit, weeks. And this is what makes this vary. An asymptomatic individual who's not tested could be spreading this disease for weeks, and nobody knows it. And that's what's so dangerous with this virus. And so, interesting, some argue that COVID is not a respiratory disease. It's an inflammatory disease that causes an autoimmune response in your body. So some will argue that it's not the virus that actually determines the outcome of the patient. It's the immune system response, which can trigger off an autoimmune response that can cause what we call the cytokine storm. I'll talk about in a second. But here's what I say about this. So when you look at autoimmune diseases like psoriasis or asthma and etc., with some of these, other ones that are listed here, these are an overreaction of your body when a stimulus is present. So for example, asthma, you could have 4 individuals in a room and there's a plume of dust that comes in that room. Individual 1 won't even notice it. Individual 2 may sneeze. Individual 3 may get cold, may get watery eyes and, feel congested. And individual 4 may go into profound bronchospasm. The stimulus is the same, but the response is dramatically different in all 4 hosts. And what you really look at here is the cytokine storm. When you have an uninfected individual, you have all these cells kind of hanging in here, ready for a battle. And then you get SARS comes in, COVID comes in, and your body says, wow, there's an invader, let's go at it. And you increase your cytokine levels, which is, you can tell you have fever. That fever is response of your inflammatory system, cough, fatigue, all right. And you have an increase in interleukins and a decrease in some of these other cells because you're using them. But when you get to severe COVID-19, the problem is that the cytokine storm increases the cytokine levels so high, and these cytokines actually cause destruction into the system, and is transmitted throughout the whole blood. So you end up getting not only now, cough, but you get ARDS, respiratory failure, and severe dyspnea, and you have blood clotting, and you have all kind of other bad type of things being released in your body, who not only go to destruct the virus, but also destruct your good tissue. So again, some argue that the cytokine storm is more responsible for the outcome in the patient than the actual respiratory virus itself. And again, this is what we want. But then when these are destroyed, or if this is too active, now you end up getting immune response out of control, and then it injures your, so this is a vicious cycle. So this is fine here, but when you have too many inflammatory markers released, then you end up causing out of control immune response. And again, you don't have this just in the respiratory. So when the body does have a cytokine storm, you have cardiovascular complications, acute cardiac injury, direct injury to heart, myocarditis, coronary. You have clotting that causes pulmonary or vascular embolization. And so you get systemic inflammation. So the virus comes in the lungs, causes release of the cytokine storm, which then causes systemic inflammation, which then causes a whole gamut of other type of problems. And with this cytokine storm, almost every organ can be affected. So again, we think of the virus affecting these organs, but it's really the body's response is affecting all these different organs. You can anything from conjunctivitis, which we can say is somewhat simple, but if you have it, it's very uncomfortable, to severe ARDS. And what you really want is in stage 2 is you don't want the patient to progress through that, because if you get into hyperinflate in phase, that's when you get into bad things. So this is where you want to block that response at this point. And that's why using drugs like dexamethasone and other type of steroids kind of make sense, because you're trying to block the inflammatory response. The inflammatory response is not caused by the virus. It's caused the body's response to the virus. Okay, a lot of individuals think that the virus causes the body to go into a, causes the body to go into ARDS. It doesn't. It's the body's response that causes it. And again, this shows effects at the alveolar level that I talked about. There goes the cytokine storm. So again, you get ARDS. Now we tried to use it. We did a trial here. So go back a slide for a second. So you see all this here. All right. So if you can block this from occurring in the lung, you can go ahead and maybe prevent the cytokine storm. So we used what was known as a JAK inhibitor, and JAK inhibitors block cytokine response. And the idea is you give a nebulized JAK inhibitor, which we did. We did 5 patients at our institution during a clinical trial. And the idea is that this medication is either swallowed or gets into the lung, and then this helps prevent the cytokine response. And the problem with this study was that it seemed to make good sense to attack the lung where the inflammation is initiated. But the problem was the way the study was designed. By the time you got to the patient, they were ready to get intubated or they're ready to go home. There was just so many exclusion criteria and so many steps in this study that I think it was a good idea, but the study had a flawed process. There's a tremendous amount of clotting during COVID that occurs. Some argue that COVID is as much as a hemological disease as is a respiratory disease. And it seems like the inflammatory proteins that are released during infection alters the function of platelets, making them hyperactive and more prone to dangerous and potentially deadly blood clots. And a lot of incidental COVIDs, like we just had one the other day, the patient did not come in with COVID per se. They didn't come in with respiratory dysfunction. They came in with a stroke, who then was put on the ventilator. We did a COVID swab, because we do COVID swabs on anybody who comes in through the emergency room, and the patient was COVID positive. They were extubated within 2 days. So they did not have respiratory sequela, but they had blood clotting from the COVID. And here's an example and those that worked in the ICU saw this all the time when we prone patients and we were dealing with COVID patients, is that they have what we call COVID toes or COVID fingers, because they have microcirculation clotting in the periphery. And again, a good amount of patients that have COVID and recover from COVID weeks later develop this blood clotting, especially in arms or in the brain. My mother-in-law, who God bless her soul, who passed away, she had COVID, recovered from COVID, and then 6 weeks later had a major stroke. And they think that was from chronic inflammatory conditions that aggravated blood clotting. And almost 14% of all hospitalized ICU patients, even that they do get rigorous thrombo prophylaxis regimes, still 23% of the patients got blood clotting, even though they ended up having aggressive care. And this was out of the University of Vienna in Austria, I mean. But the bottom line is, even with anticoagulation, these individuals still got blood clotting. And we see with the D dimers are off the chart when we get these COVID patients in that are in the ICU on ventilators. There's also neurological injuries, as I'm saying. There's a fair amount of 1 out of 7 individuals that have COVID have some kind of brain injury, may it be secondary to hypoxia, stroke, or seizures. And 28% of the individuals that do recover that have been on mechanical ventilation need long-term rehab immediately after they're staying in the hospital. And that number can be much, much higher than what we had in this first data coming out. There's increased amount of hemodialysis. Anybody who's worked in the ICUs with mechanically ventilation know that after about the 7th or 8th day, COVID patients, if they're not getting better and they have a high D dimer, I mean, this is greater than 2,600, should be less than 200, 80% were placed on dialysis. So there's evidence that there's renal clotting that takes place. So we know just recently, the other day, that we terminated care on a COVID patient because they were going to need dialysis and the family did not want to go that route any longer. But usually by day 7, if they're not getting better on the ventilator, they're going to need hemodialysis because they're going to have renal failure. So when you look at x-rays, this is a typical x-ray 3-5 days after developing respiratory symptoms. One argues that you have this multifocal lobar pneumonia that is prominent more in the bases and posterior than anterior because of the nature of the disease. And when you have profound ARDS, as you can see, this is one of our ECMO patients, you have complete consolidation of the lung and you have air bronchograms. There's the ECMO catheter in this patient. Ventilator barotrauma is extremely high in the COVID ventilated patient population because their lungs become fragile because COVID is a constant inflammatory disease that causes tissue to become very friable and very easily to become injured and ruptured. And at end stage, this is what the COVID lungs looks like. There's no area for oxygenation to take place. And unless you keep them on, this was a patient that was on ECMO for like 40 some days and there was no evidence of improvement of the lung. So we discontinued care. And this is actually one of our patients that was actually getting better from COVID, and the lung is still quite dramatically infiltrated. This is a collapsed lung. This lung is totally collapsed there. This lung is only that small. So you can see these patients that we used ECMO on, and I don't want to get into treatment because that's Al's baby. But my point is that when we used aggressive therapy on patients to try to keep them alive, that we use on severe ARDS in general, our outcomes were dismal at best. And again, this is another patient that's trached, and they don't get any better. Once they reach a certain point, there's really no lung function available anymore. It's a patient with no lungs at all, no lung parenchyma at all. The lung has totally been just devastated. The only air movement in this patient is through the trachea here and here. There's no air in the lungs at all because the lungs have become totally solidified and collapsed. On CAT scan, you can see there's evidence of that multilobar pneumonia, kind of again at the basis. And it progresses rather quickly. Day one, I was just looking at one this morning. When they came in the emergency room and got CAT scan, this is what their lung looked like. And now they're on the ventilator 7 days later, and this is what their repeat CAT scan looks like. So again, you know, it's more anterior, posterior, and that's why pronin can help. But in reality, it can be pretty diffuse. And for patients that don't do well, this is the progression you have. You go from kind of clear to basilar to now solidified in the bases. And this is the only area, you call this the baby lung, that can be ventilated. So that's why lung protective strategy with pronin is very, very crucial in this disease process. And this is a schematic of a 3D model from the University of Louisiana that shows how COVID basically spreads throughout the lung. And you can see it starts out here, healthy lung tissue, infected, and it simply goes until you have severe ARDS. So again, you don't have much functional lung tissue once you get into the very infected lung. Now, this is a picture of me when I'm helping with a bronch of a COVID patient. And this is the debris in the patient's lung. So this is a carina, and then this is the, you know, this is the right main stem, left main stem. And we have this debris in the lung, okay? This is actually, we have a picture of it, yeah. This is what we pulled out. So again, we don't have a lot of secretions with these patients as much as we have tissue death and blood clotting in the lung. I just put this in as a joke. If you complain about wearing a mask, this was the only flu mask they had in 1918. I'm not really sure what the hell this did. But again, you have what you have. So COVID-induced ARDS, ARDS is a syndrome, not a specific disease. And it can be caused by a lot of different things. And it's usually acute bilateral hypoxemic, and there's no evidence of congestive heart failure. And that's what the x-rays look like. You can have it be a primary lung injury or it could be secondary. So my point is that you can get ARDS from COVID because the heart has been injured and the patient is in severe shock. Or you can get it because it becomes infectious pneumonia because we go from viral pneumonia to ARDS. All right. So there's a primary origin and there's secondary origin. And with COVID, you can actually have both. When you look at the Berlin criteria, you look at this and you say, when you have mild ARDS, 1 out of 4 die, moderate 1 out of 3, and then severe less than over 40%, less than 50. But in COVID-19 and including the United States, the death rate has been greater than 50% on mechanically ventilated patients with ARDS. So again, these are much more, and one argues that, and I'll bring up Rich Collette's information in a second, that maybe COVID really is an ARDS. It's its own disease, and we lump it in ARDS because when you look at these CAT scans, all right, ARDS is heterogeneous, meaning there's good alveoli and there's unhealthy alveoli. So when you look at COVID patients, they have evidence of lobar, patchy, and diffuse. So the CAT scans show all different types of heterogeneous lung involvement, which becomes very problematic when you think about how to ventilate these patients. And ARDS goes through 3 phases: exudative phase or the edema phase, proliferation phase, and fibrotic phase. And you have in the exudative phase or edema phase, you have severe leakage. So watch this here. So we can get where. Normal alveoli, all the blood is where it's supposed to be in the capillary, and all alveoli are equal. This is in the edema, before the edema phase. This is normal, healthy alveoli, okay? All right. Now, when you look at the edema phase or injured alveoli, this is what you see. You see alveoli that are flooded out, blood's all over the place. And notice here, this alveoli opens up, but then collapses. So you also not only have flooded alveoli, you have ventilator-induced injury that's occurring because you're having what's known as atelectatic trauma, shear trauma. Some people call it rapid alveolar collapse trauma. Let me see if I run it again. Okay, watch this one right here. Opens up on inspiration, but then collapses. So that alveoli is being injured because it has no structural stability. And see how the deformity of it. So that's during the edema phase. Then we get into the proliferation phase, where this is marked by there's scar tissue forming, there's granulation, and gas exchange is very, very poor. And then, if the patient does survive, they get into fibrotic phase. People that do die, this is what an autopsy, what their lung looks like. It's all fibrotic and stiff. And Rich Collette makes a very good point that when you look at VD to VT ratio, large amount of wasted ventilation is a good predictor of mortality. So once you get to VD to VD ratios greater than 60%, your chances of survival is very, very low, because the majority of gas can't participate because you don't have alveolar tissue. Structural damage, you can have all these different things here that occur during ARDS. And again, this is an exploded slide. You kind of saw this early one a little bit. See, again, how can we oxygenate and ventilate patients that have severe ARDS? You have your fluid meniscus, you have your scarred alveolar capillary membrane, and the bottom line is that when you go to deliver a breath, oxygen into the lungs, where can it go? It can't. That's why you need to use positive pressure ventilation. The other problem is in this COVID and also in ARDS in general, you have the same problem. If I bring a tidal volume of 400, where does it go? The majority goes into the good portion, good alveoli. You overinflate them and injure them, and the majority doesn't get here and just remains sick. So that's why even lung protective ventilation, there's no guarantee of equal gas distribution. And liver lung appearance, the lung is hemorrhaged, it's dependent in general. You can see here the apices are spared, even though this guy's a heavy smoker and there's evidence of smoking damage. The ARDS is more located in the base of the lung. The lung is wet and heavy. If I ripped out my lungs right now and threw them in a vat of water, they would float and I'd be dead. But if you take the ARDS lung and you put them in a vat of water, they would sink right to the bottom because they're edematous and they're filled with fluid. And on autopsy, there can be a lot of viscous mucopurulent secretions coating the airways. Now, here's healthy lungs, and this is what the COVID lung looks like. So here's a guy that got they cut out a COVID lung to put in good lungs. And you can see, how can you oxygenate and ventilate when this is somebody's lung? It looks like a rock that comes out of the soil. It's quite eye-opening. We know this. Now, the work of breathing that's associated with COVID spontaneously breathing can be equal to blowing up 300 million alveoli. So this is why you see some patients that are severely tachypnic and dyspneic with COVID ARDS. Others you don't. We'll talk about that in a second. And this is what they may look like. They may not look this buff, but this is the work of breathing that can be associated with ARDS prior to intubation. Now, Gattinoni, who's a pretty cool individual, I've had the pleasure of meeting him in a bar in San Francisco, who talks about two different types of ARDSs. So he talks about what's known as the happy hypoxia. These are individuals that have COVID pneumonia that have good compliance. They don't have a lot of dyspnea. They don't have a lot of fluid in their lung, and their gas volume is normal. And it's really more of a hypoxic vasoconstriction. And you'll look at them and you'll say to them, hey, how do you feel? And they'll say, how do you feel? And their saturation will be 85% on 100% oxygen, high flow, NRB mass. And they don't show signs of hypoxemia. But if you did a pulmonary function study on them, their volumes would be good, like their FEVCs and stuff like that would be good, but their diffusion would be poor. Their DLC would be poor. So that's one group. And you look at the treatment of this phenotype and you would treat them. They have a higher threshold for intubation. So let's not intubate them until never, if we can, because we won't intubate them until they end up saying and begging to be intubated. Early prone works very well with them. They usually need a higher FiO2, but they don't need a lot of PEEP. And one would argue they would probably use a higher tidal volume because their mechanics are fairly good. They don't have a true ARDS lung. Type H, which is, the very noisy hypoxic, they're short of breath. Their lungs are very compressed. They show the characteristics of severe ARDS. And if you did PFTs on them, their volumes would be down, their diffusion would be down. And these are individuals that are begging you to get intubated and have very poor pulmonary reserve and cannot do self-proning or any of those other type of things that we try to do to try to prevent intubation. And early intubation, high PEEP, paralyze them, prone with inhaled pulmonary vasodilators. And these are ones that we would think about putting on ECMO at that point. Now, I put this in because this is fresh data, and I read this and I actually talked to Rich Collette personally. I found this to be very, very intriguing. Rich Collette argues that when you look at the data from mechanically ventilated patients the first year of the pandemic, he argues that he doesn't think that COVID is true ARDS, but it's more of a multifocal pneumonia associated with pulmonary vasoconstriction and lung tissue inflammation. ARDS may occur later in disease, but it's not an ARDS, and we should stop treating it as an ARDS at this point. So that's a very interesting article. It's in the Respiratory Journal this month, volume 66, pages 1341 to 1359. I did not have time to try to get a lot of information in there, but the argument is that we may be trying to treat patients that don't have ARDS with ARDS methodology and technology. Outcomes, they can be dismal depending on what data looks like. The early data that came out of Wuhan showed that obviously the older you were, the higher death rates were. Their mean death rate was 65.8, and 73% of them were men. COVID-19 admissions, again, a large group of it was between 65 and 85, some 45 to 64. This was early in the pandemic in the United States. Now, 85 plus, hopefully you don't intubate a lot of people that. But the bottom line, it was a disease that was thought to be the original COVID, more of the elderly individuals, which I now fit in that group. And again, the death rates show the same thing. And this was early on. So this was May 30th of 2020. And again, most of the information says that, again, the older you were, the more chance of death with COVID is. And these were now the characteristics of young individuals. So you have young individuals between the ages of 18 and 34 that ended up going on mechanical ventilation. There was a higher degree of Hispanic and Blacks, and there was also a higher degree of mortality and diabetes and hypertension. So younger people who were obese, who were hypertensive and diabetic, had a higher chance, and if they were Latino or African American, they had a higher chance of going on mechanical ventilation and dying. And again, you have no risk factors, your chance of death is very minimal in young group. But when you add the risk factors, the chance of death increases significantly. So the mortality in mechanically ventilated patients early in the pandemic was kind of interesting. Some people like New York, I think, was very honest. They had 90% mortality in mechanical ventilation. Boston said they only had 22%. Emory only had 26%, and Duke only had 28%. But notice the end, the volume. The volume was very high in New York City. So as you increase volume, the percentage of death increases dramatically. Now, I want to show you some of our outcome data here. So this was November 2020. So this was after the first surge. So after the first surge, we had 51% liberation out of 234. And we had 41% died and 21 were still on the ventilator. So these were still unaccounted for, all right? And these are different campuses. So we had 115 patients in Surge 1 at Lehigh Valley, Cedar Crest, our flagship hospital, and 234 total, all right? Then we look at May 1st. So this is now after, basically the second surge. Notice what happens here. The numbers increase dramatically, okay? But notice the outcomes here. In the second surge, our outcomes were much poorer. We are now only 43% liberation compared to 55%, all right? So that surge was still going on as May 1st. It wasn't quite over. We had 11 patients on ventilators. This was June 21st, so this is really after the surge. And that data is 600 total, and it kind of remained the same. We had 54% death, 46% liberation. Now, be careful with the word liberation. That means they left the hospital alive. Some of them were still on vents with trachs. We don't know what happened to them afterwards. Many of these patients, unfortunately, died when they left the hospital at tertiary cares or LTAC units. So the COVID-19 reduced Americans' life expectancy by 1.13 years. In African Americans and Latino, it decreased their life expectancy by 2.1 years. So 1 year of a pandemic had that kind of impact, and it decreased the lowest life expectancy since the last 40 years. Okay, so think about that. 1 year of a pandemic made that much of an impact. Okay, so I want to just go through here real quick that again, these long haulers real quick. I just want to finish up here because I'm running out of time. Third of COVID survivors have long haul symptoms. This is very, very important because individuals that have survived, even mild cases of COVID have loss of taste or smell for long periods of time. They have fatigue, they have brain fog, and this brain fog can be severely making individuals dysfunctional and incapacitated. And nearly 31% of people who had COVID said they feel worse health-wise than before having COVID, okay? Most don't recover for after 6 months. There's a whole host of symptoms, fatigue, dyspnea, symptoms of depression. Our PFT people, very interesting. They will say that they get a lot of individuals in with PFTs that have normal PFTs post-COVID, but they have very little respiratory reserve when it comes to exercise, and they have continuous shortness of breath even at rest. But there's no evidence that there's impairment of even DLCO, which would look at diffusion of gas. So you have fatigue, headaches, insomnia. Well, we have a nurse that had COVID early on in April of 2020, never returned back to work. She was a triathlon athlete, and she can't function. She can't concentrate for periods greater than a few hours. And some days she can't concentrate at all. Very lot of psychiatric or neurological disability. There's over 200, this was out of the Lancet in England, over 200,000 post-COVID patients showed some evidence of neurologic or psychological disability. And these were anywhere from memory loss, nerve disorders, anxiety, depression, substance abuse, insomnia. And again, what effect does COVID have on the body long-term after acute symptoms have resolved? We don't have an answer. We don't have an answer. That's the fear of this. This pandemic, even if it subsides, which I don't see it doing it for quite a while, the long-term effects could be, lasting for decades. Okay. And do they believe that the long-term effect of this is really the effect of the immune system, that there's not actually a evidence? So on autopsy or when they do brain biopsy, they don't see evidence that there was blood clot in the brain. They don't see that there's actually injury to the brain. So they think it's really the long-term effects of the immune system and the virus tricking the body into producing a persistent inflammatory response resistant to treatment. Okay, so chronic fatigue syndrome is extremely common among these. And then that leads to a whole gamut of other type of vicious cycles. Now, again, this I put in here, and again, I don't make judgment on people that don't get vaccinated. Everybody has their own, their own reasons. But I would say that a lot of individuals that after they get COVID beg that and wish they would have got vaccinated. And this is an individual that was a young guy, 24 years old, who got COVID somewhere in April when he was visiting Florida. He got severely sick, was on a ventilator, and he was transferred to the Maryland Medical Center, and he ended up actually now getting a lung transplant. And here is the individual, all right? And he argues the point that, please get the vaccine. But the problem is, once you're that sick, the vaccine's not going to help. Now, the other thing is, and again, this isn't patient related, but I want to put this in here, is many ICU staffers have experimented mental health disorders in the COVID-19 pandemic. I'm one. I'm telling you, back in May, I really felt that I was on the edge of having a nervous breakdown, seeing so many people die, so many people just, even our healthcare workers falling over of exhaustion. And they also found that individuals that kept, had to be in PPE for greater than 40% of their shift, more than 6 hours. So that's, when you're working 12-hour shifts, that's half your shift. Also found increase in these conditions. So it wasn't just individuals who took care of these patients. It was individuals that had to deal with not being able to breathe and having the pressure of a, PPE on my face, and I actually have had some scarring on my face from wearing the N95 for hours after hours. So in conclusion, I wanted to say that COVID-19 pathophysiology is just more than a respiratory dysfunction. This is not something that just causes respiratory problems. Yes, it may enter through the respiratory system, but it's much more than a respiratory disease. The body's response to the disease may be more deadly than the disease itself. The cytokine storm, I think, can be very, very responsible for death. And there's a subset of COVID patients that symptoms continue to manifest long beyond recovery. And the fourth thing I would add, that we really don't know how to treat COVID. We treat it and lump it in as ARDS, but it may be its own entity and may need its own ventilatory strategies and other respiratory support that we're not using currently. So there's more stuff on that. So again, that's the end of my two presentations. Again, I want to thank you guys that have been working at the bedside. You're all heroes in my eyes. And please be safe. And hopefully we've been able to give you these two lectures some information that can be useful for you. And Al and Terry will give you tremendously more information and kind of segue on to what I presented.